Welcome back, everyone. I'm Dr. Khan, and I'm joined by the incredibly precise Dr. Sarah. Today, we are diving into a topic that keeps orthopedic surgeons up at night, Volkmann's ischemic contracture. Now, last time we covered general upper limb anatomy, but today is all about what happens when that anatomy goes terribly wrong.
Exactly, Dr. Khan. And while it sounds complex, for board exams, it's really a story about the brachial artery. If you understand the blood supply to the forearm, you understand the pathology. Volkmann's is essentially the end-stage result of untreated compartment syndrome, usually following a specific type of injury.
Right. It's the horror movie ending of a supracondylar humerus fracture. Imagine a 10-year-old kid falls off the monkey bars. He breaks the bottom of his humerus just above the elbow. Clinically, why does this matter so much? It's because the brachial artery is sitting right there, vulnerable. Dr. Sarah, how do the boards usually frame the start of this disaster?
They will almost always present a pediatric patient with that supracondylar fracture. The key high yield point is the mechanism. The sharp bone fragment or the massive swelling causes the brachial artery to go into spasm or get compressed. Think of it as a kink in a garden hose. No water, meaning no blood, gets to the forearm flexors.
I love that garden hose analogy. If the hose is kinked at the elbow, the grass in the forearm starts to wither. But here's the clinical kicker. It's not just the fracture itself. Sometimes it's the doctor. If we apply a cast that's too tight while the arm is swelling, we create a high-pressure, slow cooker environment. The pressure inside the fascia rises so high that it shuts down the microcirculation. Dr. Sarah, what are the 5 Ps our students need to memorize for the exam?
This is a classic board favorite. You're looking for pain, pallor, pulselessness, paresthesia, and paralysis. But here is the nuance. Pain out of proportion to the injury is usually the earliest and most reliable sign. If the patient has excruciating pain when you passively extend their fingers, that is a massive red flag for impending ischemia.
That passive stretch test is everything in the ER. Why does this matter clinically? Because muscles can only survive about 4 to 6 hours without blood before the damage becomes irreversible. If you miss that window, those beautiful flexible flexor muscles like the flexor digitorum profundus literally die and are replaced by tough, non-elastic scar tissue.
And that replacement with fibrous tissue leads to the signature Volkmann's claw. The scar tissue shrinks, pulling the wrist into flexion and the fingers into a permanent, hardened claw. It's a devastating deformity. From an academic standpoint, remember that the deep flexors, like the flexor pollicis longus and the profundus, are usually the most severely affected because they sit closest to the bone where the pressure is highest.
It's tragic because once that contracture sets in, you can't just stretch it out. It's a permanent shortening. I always tell my residents, if you're the one who recognizes the signs early and cuts that cast or calls for a fasciotomy, you become the patient's doctor of choice for life because you literally saved their hand function. If you miss it, the hand becomes a non-functional hook.
That's a great point. Another board-relevant detail is the nerve involvement. While the muscle death is the main event, the median and ulnar nerves also travel through those tight compartments. So if a student sees decreased sensation in the thumb and index finger following an elbow fracture, they should be thinking about the pressure rising in that anterior compartment.
Exactly. It's a total neurovascular collapse. So let's wrap this up with a clinical why. Why do we care so much about Volkmann's? Because it is entirely preventable. If you see a kid with an elbow injury, you check those pulses, you check that capillary refill, and you never, ever ignore a patient who says their cast feels too tight.
Perfect. To summarize the high-yield facts, Volkmann's ischemic contracture is the result of brachial artery obstruction or compartment syndrome, typically after a supracondylar fracture. It leads to muscle necrosis and fibrosis, resulting in a permanent flexor claw hand deformity. Early diagnosis via the 5 Ps, especially pain with passive stretch, is the only way to prevent it.
Great summary, Dr. Sarah. Keep those garden hoses unkinked, everyone. We'll see you in the next episode.